Hello everyone, and today we are going to work on a very complex CTO case with the LED totally occluded. This is a 41 years old male and suffer from chest pain for 5 months. Risk factor are hypertension and diabetes for two years. Injection fraction is 70%. Laboratory data almost normal. This is the electrocardiogram. From this picture, you can see Q wave in leads V1 to V4. Elevated ST segment in leads 3 and AVF. Depressed ST segment in leads 1 and AVL. This is angiography on February 4th. From this picture, from this meeting, you can see there's a stemless CTO lesion attracts small LED, and you can see there's then in the circumflex. And this patient did the circumflex standing operation about 3 years ago. About 50% stenosis at the distal circumflex. This is a right coronary artery angiography, and it's very long, diffuse, mild stenosis, right coronary artery. You can see there's some contralateral to support the LED, just like PL maybe, and there is a set branch from the proximal right coronary artery to support the left anterior descending. During the last operation, the operator planned to treat this CTO lesion with the integrated approach. And the operator used second, Gaia third, and Conquest Pro to puncture the CTO proximal cap with the support of Corsair microcatheter. However, unfortunately, getting there failed to enter the distal true lumen.
This patient is a proximal LED total occlusion and should be a small stem here, but with severe calcification. And the length, I think, more than 20 millimeter. And the patient, like we could see today's angio, we can see the patient with anomalous RC osteum. And certainly, this time we also use our AI visualization system to reconstruct patient CTA. But very interesting, as we know, CTA sometimes also accuracy couldn't be 100%.
Yes.
So the CTA told us the LED is patency, but we can see this is the reconstruction of the CTA imaging. We already did angiogram. The LED is still occlusion. CTA has some limitation, but it's not the limitation of the artificial intelligent visualization system. This is because of the baseline data.
Yes.
The baseline data told the AI system, so the LED is patency. We could know clearly the distribution of the lesion and the vessel. This is the AP cranial view. We can see the reconstruction showed its patency, but really it is, in fact, it is occluded. But we can see severe calcified lesion in the proximal LED,
Yes.
and only a little bit soft plaque. Most are calcified lesion. This is why the first time a very well experienced operator, CTO operator, couldn't successfully recanalize the CTO lesion. We can see very clearly the calcified lesion distribution. And there should be a small stamp osteum of the diagonal branch. And certainly, I think cap is very stiff. And the first time, the operator used CP wire, make the wire come to the CTO body, but still couldn't come to the distal true lumen. And after in the distal part, just at the diagonal branch area, there is no large calcified plaque. This is the first angiogram. We can see this is really anomalous osteum RCA, and we use one femoral and one video approach. This is really a very big guy, very young but a very big guy, patient with OSAS. And the RCA angiogram, we can see some collateral channel, the distal RCA, and with diffuse lesion, especially in the should be in the third portion segment. There should be some relative unstable plaque here. We can see clearly. So if we use retrograde approach, we may firstly use imaging to check the place and maybe implant a stent there, and to make the retrograde approach is safe. Okay. And let's see, another is the RO view. RO is often used for us to check the collateral channel, separate collateral channel, but we can see we couldn't see very clearly. In order to better do the RC angiogram, and finally we use Godzilla to a little bit deep engage to the RC ostim, and the RO view we can see no very good septal-collateral channel. There should be a relatively good septal-collateral channel, but the exit point is very close to the distal fibrostic cap. This is the bilateral angiogram REO cranial. We can see the occluded segment and the LED with calcification. And we can see in the middle portion of the LED, just that the diagonal branch area is patency, but before the diagonal branch with some plaque. Let's see the AP view. Certainly, we could sometimes try retrograde approach, but we must check the RC first. So if there is a stable plaque or severe stenosis, but there is no very good septal-collateral channel. So certainly for that case, I think we may try antegrade approach first.
And as the IS caster is pulling back, we can see that from the 4 o'clock to 6 o'clock, there is a main LED vessel joining into the side branch. And from this one, we can see it's the LED occluded segment. And also here is some hint for our next procedure. First, it's a very big LED vessel. It's joining into the side branch. And also at the opening of the side branch from the CTO segment, it's very clear. There is almost no plaque. Second thing is that there is some mild calcification on the side of the occluded LED, so which may cause some problem to the antegrade puncture during the next antegrade procedure. And here we can see that this is the occluded LED. Here, this is might be the entry point of the CTO segment. This is what we can see from the IVAS, Professor Lee. So we can see that Professor Lee is performing the knuckle technique using a hydrophilic coated wire. And actually, I think that this is a very dramatic CTO case with a blunt tip of the proximal and occluded LED. There are several things that I think that we need to discuss in full details. First thing is that I think this one is JCTO score 3 case. There are several things. First, is occluded segment is over 20 millimeter from the CTO reconstruction and also from
at that
the
time,
lateral angiography.
I think we're already in knuckle.
Yes.
So the antegrade contrast injection should be avoided.
Yes. Yes.
Yeah. So we should use a contralateral angio. Okay.
To avoid the potential antegrade dissection and hematoma, which means that from now on, the angiography from the antegrade should be avoided. Professor Lee is working on the ADR techniques. There are several issues I think that we need to clarify during the ADR techniques. For this case, although it's a LED occluded segment, we can see that we may try our best to avoid all the important side branches. So this is I think that's number one information that support us to perform the ADR techniques. And the second thing is that we can see that the antegrade knuckling techniques successfully goes to the distal part of the occluded segment next to the distal cap. And also that why we do not try to perform cross-pulse catheter to try to engage to the distal part of the CTO segment. There are several things. First thing is that I think knuckle wear can relatively cause less damage compared to the crossballs. And also like this kind of calcification cases, I think that it's relatively easy to engage to the distal cap of the CTO segment. And the next thing is that during the delivery of this stingray balloon, we can see that Professor Lee has just delivered the balloon to the relatively optimal site to try to re-entry to the distal true lumen. And now we opened this stingray balloon to relatively low pressure. It's a full atmosphere, I think.
So the balloon must be well prepared. Sometimes if the balloon was not very well prepared, we couldn't see the balloon. And the optimal view, the stingray balloon should be one line. Let's choose okay. Choose a view to make the make the stingray. I should be in one line here.
Yes.
Okay, could we see? Okay, here should be in one line. Okay.
So we are choosing
Okay.
the right projections to maintain that this balloon, I mean the bilateral side into the Y line.
Yeah, okay.
To choose the perfect puncturing direction.
And we routinely use palm to be straw. Also, there should be not a large chamber, pseudo chamber, but we still use palm to. Yeah, okay. Sometimes we can see some black flow by. Last time, I think no big hematoma.
Yes.
The more calcification the lesion, the less the formation of the hematoma. Okay.
Yes,
At
and
that time,
also
I think we should make a contralateral angiogram. Okay. To make sure where is the direction of the true lumen. Not very clear. Okay.
Yes, because we know that this case doesn't
We use contralateral angiogram to recheck the position of the.
Yes.
Okay.
I think that confirming the distal reentry site is of key importance.
Okay. I think we should advance a little bit
Yes,
further.
because we can see from the collateral, I mean retrograde angiography that the reentry site might be a little bit proximal to the second diagonal, and which means that we could, I mean, engage the stingray balloon a little bit further to increase the reentry successful rate.
Third. Look like very close to the.
Yes, yes, maybe so.
Cranial.
Yes, we change a little bit our strategy to check the position of the wire.
So orthogonal view. Okay. Angel. Other. Okay.
So, Professor Lee, do you think you want to, I mean, engage the Gaia wire a little bit further to?
Sorry.
Okay, I think that one of the, I mean, most difficult issue of this patient is that the collateral flow from the RCA is not sufficient enough. I mean, to make a very clear, I mean, identification of the distal, I mean, true lumen.
I think the wire should be in the subintimate space.
Okay.
Okay. The feeling told me subintimate space.
So maybe it's potential, I mean, reentry point or something.
Test a little bit. Okay. Could be as
yes,
like
or maybe it,
like.
Yes.
Okay.
Or maybe it's in the, I mean, track from the maybe
advance a
3
little
months
bit
ago attempt.
blown. Here. Okay. Advance a little bit further. Okay.
The second diagonal is still at the distal part of this, I mean, stingray balloon. So reentry at the current spot doesn't, I mean, influence too much of the perfusion or the myocardium from the left ventricular. So according to the CTO algorithm flowchart, we can see that this CTO case is a blonde tape. I mean, relatively long. I mean, over 20 millimeters CTO segment.
Okay.
And also that we can see it's a favors for ADR very much, which explains our strategies.
CT where, please. Okay. So let's choose
So we are switching to a relatively distal part of the stingray balloon to make a second attempt of the ADR wire puncture.
Okay.
So like the demonstration of Professor Lee, I think there are several things very important during the anti-grid ADR techniques. Like I just explained, the right position, of the re-entry point is of key importance. So we may check which is the right re-entry point from the retrograde, angiography, to make sure that we will avoid all the main side branches, and also we can see very clear the distal, the distal retrograde flow to make sure the re-entry point, which means the true lumen.
On the back, please. Okay, can we see? Not in one line.
No, maybe no.
Okay, epicaudal.
Yes.
Choose the angle.
So we can see that we are trying different kind of projections to seek the best, projections.
RU. Yeah. Okay, I see. RU auto P. So in this direction,
yes, I think this
should
is
be one
yes.
line. Okay, that's fine.
The bilateral side of the stingray balloon is, coexist into the one line, which means that the whole balloon is at the horizon, situation, makes us relatively easy to identify the puncture direction, which hole we are cruising, and which, direction we are trying to go.
Okay. So
I think that the audience is quite interested in our case. And whether is there any questions from the audience?
new palette 200.
So we are still using the pilot 200 to try to puncture into the true lumen.
And we should enlarge the picture and use this.
Okay.
That.
So Professor Lee, do you think the calcification within the CTO segment is an issue of this, puncture difficulty?
Okay. Okay. Okay.
Okay.
So where is the true lumen?
I think that from the collateral angiography, I think it's, for me, maybe it's from the upper side. Okay.
Okay, end your game. Okay. Stop. Not very clear.
Yes, because there is some, mild diffuse calcification, which, influence the identification of the distal entry point. So maybe I think that
the straw may help. So if the distal true lumen is large, when the puncture wire come into the true lumen, we could use sticking the drive strategy. But if the distal true lumen, you couldn't make sure if the wire come into the distal true lumen, sometimes we may try sticking the swab.
I think that for the current situation, second swap should be a good choice because it's relatively difficult to see the re-entry point.
Okay.
The primary tenet of the non-CTO PCI is to avoid wire penetration into the sub-adventitious space, as this may raise the plaque, and also further impairing the coronary flow and potentially causing myocardial infarction. However, a significant leap in CTO PCI success rates would come from the unconventional approach.